It's time for the 3-question warm-up for Heme 5. Let's get going. How does hexokinase differ from glucokinase? Well, first of all, the location is different. Hexokinase is found everywhere, while glucokinase is only found in the liver and the beta cells of the pancreas as well. Insulin does not induce hexokinase, but it does induce glucokinase. And then hexokinase has low Km and low Vmax, but glucokinase is just the opposite. It has a high Km and a high Vmax as well. Next question, what substrate and cofactor is required for the generation of GABA? So the amino acid glutamate is essential for the production of GABA, and glutathione is another important antioxidant as well. So to answer the question, the substrate is glutamate and the cofactor is vitamin B6. Next question, what medication inhibits alcohol dehydrogenase? Which medications inhibit acetaldehyde dehydrogenase? Well, fomepizole is going to inhibit alcohol dehydrogenase, and then disulfiram inhibits acetaldehyde dehydrogenase. All right, that's it for the warm-up. Let's get to that lecture now.
Over the course of the next few videos, we're going to review various types of anemia. Now, anemia is a huge topic and very, very high yield. Although, again, you're likely to get softball kinds of questions about classic presentations. But this is also a very important clinical concept to be able to think logically and systematically about what might be causing your patient's anemia. Now, one very common way to think about anemia is to start by dividing up the causes of anemia based on the size of the red cells. Are they too small or microcytic? Are they too large or macrocytic? Or are they just right or normocytic? Now, we're going to review microcytic anemias in this video, and we'll review macrocytic anemia and normocytic anemia in later videos. So, what number on the CBC is going to tell you how big the red cells are? It's the MCV, or the mean corpuscular volume. So usually the first thing your attending is going to want to know when you start talking about anemia is, what's the MCV? And you're going to see lots of different complicated diagnostic algorithms for what test to order next and so on. But for your exam, you just need to be able to sort of lump the different types of anemia into microcytic and macrocytic and normocytic, and then split the normocytic anemias into hemolytic or non-hemolytic. So let's start with microcytic anemias. By far the most common cause of microcytic anemia is iron deficiency anemia, maybe from poor iron intake, or more commonly in the U.S., which is the land of iron supplements and red meat and iron-fortified breakfast cereals, more commonly we're going to see blood loss causing iron deficiency anemia. Now, it could be normal physiologic blood loss, like menstruation, or it could be abnormal blood loss, often GI blood loss, maybe from colon cancer or a peptic ulcer or something like that, where you have chronic occult blood loss. So if on your test they give you a patient over the age of 50 with iron deficiency anemia and no easily identifiable cause, you need to rule out colon cancer. That patient needs a colonoscopy. You can also potentially see iron deficiency anemia due to increased iron demand, like in pregnancy. So with pregnancy, you might see an iron deficiency anemia, but there's also something called physiologic anemia of pregnancy, where the plasma volume is increasing at a greater rate than the red cell mass, so the red cells are diluted out, and there's relative anemia. Now, with iron deficiency, the red cells are microcytic, and they're small, and they're hypochromic, or pale. And you might also see something called Plummer-Vinson syndrome, which is a triad of iron deficiency anemia, esophageal webs, and atrophic glossitis. It's one of those things you're more likely to see on a test than in real life. There are lots of nutritional causes of glossitis, inflammation of the tongue, especially B vitamin deficiencies, but you need to remember that iron deficiency can do it as well. The next couple of microcytic anemias are the thalassemias, starting with alpha thalassemia. So thalassemia is caused by a defect in globin synthesis. So remember, hemoglobin is made of 4 globin proteins. In the last video we talked about lead poisoning and porphyria as defects in heme synthesis, but thalassemia is a defect in globin synthesis. And again, normal hemoglobin A is made of 2 alpha globins and 2 beta globins. Now, alpha thalassemia occurs when you have a defect in alpha globin. Either your alpha globins are defective or you just don't make enough of them. And there are different degrees of alpha thalassemia which are related to the genetics. So normally you have 2 alpha globin alleles on chromosome 16, and you get 1 copy of chromosome 16 from mom and 1 copy from dad. So that's a total of 4 alpha globin alleles. Now, if you have a deletion or mutation in one of those alleles, that's pretty mild. And the other alpha alleles can still make plenty of alpha globin, so you have plenty of hemoglobin and no anemia. Now, if you have 2 mutated alleles, that's still pretty mild, and we call that alpha thal trait or alpha thal minor. And in general, that's not associated with any anemia either. But when you mutate 3 of those alleles and you're just left with 1 normal alpha gene, that's called hemoglobin H disease. So here you're making a ton of beta globin and very little alpha globin. So those beta globins start to pair up with one another, so that a substantial amount of the hemoglobin is made up of 4 beta globins, and that's called hemoglobin H. Then, if you're deficient in all 4 alleles, that's incompatible with life. You don't ever get to the stage where you're making beta globin, because as a fetus, you make all gamma globins instead of beta globins. So instead of hemoglobin H, the fetus has hemoglobin Bart's, which is made up of 4 gamma globins, that other component of fetal hemoglobin. And that hemoglobin Bart's is going to cause generalized fetal edema, which we call hydrops fetalis, and then death. So mostly, if you see alpha thalassemia at all, you're going to see alpha thal trait with minimal anemia. It's more prevalent among Africans and Asians. Remember, alpha, A, Africans and Asians. Then the other type of thalassemia is beta thalassemia, which is still a defect in globin synthesis, but with beta thal, we're talking about a defect in the beta globin gene. And beta thal is seen in Mediterranean populations, so make sure to make that distinction. Alpha thal in African and Asian populations, beta thal in Mediterranean populations. So instead of 4 alleles like with alpha globin, you just have 2 genes for beta globin. But again, you could have a mutation that makes abnormal beta globin, or you could have a mutation that makes no beta globin whatsoever. So beta thal minor is where you have decreased amounts of beta globin. You have minimal anemia and increased hemoglobin A2, because hemoglobin A2 is made up of alpha globin and delta globin. You don't need beta globin to make hemoglobin A2. And then beta thal major is where you have no beta globins whatsoever. So you have severe anemia requiring blood transfusion, and that can lead to hemochromatosis with repeated transfusions. Now, how would you counteract that hemochromatosis? You're not going to do phlebotomy, right? That's kind of counterproductive to remove the red cells you just put in. So instead, you're going to use an iron chelating drug like deferoxamine. In fact, in a patient with microcytic anemia, you always want to make sure to check iron studies and confirm the diagnosis of iron deficiency before you start iron supplements. Because if you miss the diagnosis of beta thal minor, you can actually cause iron overload. So you need to check the iron studies, and you may need to check a hemoglobin electrophoresis and make sure they don't have high hemoglobin A2, because again, that would suggest beta thal minor. On the peripheral smear in beta thalassemia, you can see target cells. Again, the mnemonic for target cells is thal, thalassemia, hemoglobin C disease, asplenia, and liver disease. So all of those things can cause target cells. And with beta thal major, your bone marrow is all ramped up trying to make lots of hemoglobin, so you're going to see marrow hyperplasia. And that hyperplasia in the marrow of the skull creates this hair-on-end appearance of the skull X-ray. So we're going to see this in sickle cell disease as well. Sometimes it's called a crew cut appearance, same thing. The skeletal deformities in beta thal major also result in chipmunk facies. And in both thal major and thal minor, you have increased hemoglobin F, which just makes sense. If you have no beta chains, how else are you going to make hemoglobin? Well, you're going to use hemoglobin F, which is 2 alpha globins, which you have plenty of, and 2 gamma globins. It can also get very complicated if you are heterozygous for a beta globin mutation and for a hemoglobin S mutation, which causes sickle cell disease. That's going to cause mild to moderate sickle cell disease, depending on how much beta globin is actually being produced. Another cause of microcytic hypochromic anemia is lead poisoning. So we've already talked about lead poisoning as a cause of defective heme synthesis, and you can see basophilic stippling on the red cells. We talked about all the non-hematologic features of lead poisoning, especially those neurological manifestations and the lead lines on the gums and in the bones. I'm not going to go through all that again right now. But remember that the 2 heme synthesis enzymes that are affected by lead poisoning are ferroketolase and ALA dehydratase. And we talked about how lead poisoning probably doesn't cause sideroblastic anemia. Remember, sideroblastic anemia is a result of defective heme synthesis, and you see those ringed sideroblasts in the bone marrow. And we mentioned that lots of different things can cause sideroblastic anemia. There's a hereditary form. You can also see sideroblastic anemia from chronic alcohol use or from certain drugs like various seizure drugs and isoniazid and chloramphenicol. And with sideroblastic anemia, you might see elevated serum iron levels and elevated ferritin because that iron isn't being used to make heme, so it's just kind of piling up. And we can often treat sideroblastic anemia with B6 supplementation. There's also a condition called anemia of chronic disease, which is caused by defective iron utilization and defective iron mobilization. We're going to see this in patients with chronic inflammatory diseases, especially things like rheumatoid arthritis, chronic infections, sometimes with malignancy. Sometimes it's called anemia of chronic inflammation. So you have this chronic inflammation that interferes with your body's ability to use iron. So the iron is basically trapped in macrophages, and the ferritin is normal or high, but the serum iron is low. This will often start out as a normocytic anemia, but if it's allowed to go on long enough, the red cells will start to become microcytic and hypochromic. So we're going to come back and talk about anemia of chronic disease again with the normocytic anemias, but again, it's not at all uncommon for anemia of chronic disease to cause a microcytic anemia. If iron deficiency anemia is the most common type of microcytic anemia, the first thing you're going to do when evaluating a patient with microcytic anemia is check the iron studies. So let's talk about how we use those lab results to help make the diagnosis. In the first two rows, we have iron deficiency anemia and anemia of chronic disease. And in both of these, the serum iron level will be low. The next column is TIBC, or total iron binding capacity. So this is a measure of how much transferrin is in the blood. Transferrin is a protein that transports iron in the blood. So anything that elevates transferrin is going to elevate TIBC. So transferrin is elevated in iron deficiency, but it's low in anemia of chronic disease. If you're iron deficient, your body is desperate to transport iron from storage to the bone marrow where it can be used. So your body's going to make lots of transferrin, and TIBC will be elevated. But in chronic disease, even though serum iron is low, that's not the main problem. So transferrin will be low. And the next column is ferritin. So ferritin is a storage form of iron found inside of cells. So in iron deficiency, you've used up all the stored iron, so ferritin is going to be low. But in anemia of chronic disease, ferritin will generally be normal or elevated, but definitely not low. Remember, ferritin is an acute phase reactant. It's usually going to be elevated with any type of inflammatory process, so infections, cancer. So ferritin can be elevated for a lot of different reasons. One of those reasons is anemia of chronic disease. Then the far right column is percent transferrin saturation. So that's the ratio of serum iron to TIBC. It kind of tells you how much of the transferrin, that iron transport protein, is saturated with iron. And this value will generally be calculated for you when you order iron studies. In iron deficiency, the transferrin saturation is going to be markedly decreased because you've got a lot of transferrin out there, but you don't have much iron. So the percent saturation is going to be very, very low, usually less than 12%. For anemia of chronic disease, it's generally going to be in the normal range. Now, the normal range for transferrin saturation is anywhere from about 12 up to 45 or 50, so it's a very broad normal range. But generally, in anemia of chronic disease, you're going to have a transferrin saturation greater than 18%. Now, what do these iron studies look like in hemochromatosis? Well, hemochromatosis is where you have a lot of iron stored up. You have too much iron in the body. So serum iron will be elevated. TIBC and transferrin will be low because the transferrin is basically saturated. There's too much iron, so your body's not making more transferrin. Ferritin will be elevated. If you have normal ferritin, you can pretty much rule out hemochromatosis. Now, if you have elevated ferritin that doesn't prove you have hemochromatosis, we said ferritin can be elevated for a lot of different reasons. So elevated ferritin doesn't prove there's hemochromatosis, but normal ferritin pretty much rules out hemochromatosis. And then in hemochromatosis, the percent transferrin saturation is going to be very high. Again, you have lots of iron, all the transferrin is saturated, so transferrin saturation is very high. Then what about sideroblastic anemia? Remember, sideroblastic anemia is due to impaired heme synthesis. So you should be able to reason out what it's going to do to these iron numbers. Iron and ferritin are both elevated because your body's not using iron to make heme, so you've got a lot of extra iron lying around. And whenever there's too much iron, the transferrin and TIBC are decreased. And since iron is elevated and there's lots of iron bound to transferrin in the serum, the transferrin saturation is going to be normal or elevated. And the overall transferrin or TIBC is going to be decreased. So the iron studies in sideroblastic anemia look a lot like the iron studies in hemochromatosis. The difference is that with hemochromatosis, there's no anemia, just too much iron. Now it's time for the end of session quiz. So I want you to pause the video, go through those questions, and then we'll go over the answers together. First question, what test can be used to diagnose beta thalassemia minor? We're going to do a hemoglobin electrophoresis to look for higher than normal levels of hemoglobin A2. Next, a patient is found to have microcytic hyperchromic anemia. What lab findings allow you to distinguish iron deficiency anemia from anemia of chronic disease? Well, in both of these, serum iron will be decreased. But in a patient with iron deficiency, they're going to have increased TIBC, decreased ferritin, and transferrin saturation will be low, less than 12%. Now, a patient with anemia of chronic disease will have decreased TIBC, ferritin will be normal or elevated, and transferrin saturation will be normal, greater than 18%. And the last question, what should you rule out in a man over 50 with new onset iron deficiency anemia? You need to rule out colon cancer. Now really, you need to rule out colon cancer in both men and women, but colon cancer is more prevalent in men than in women. We also have some rapid fire facts. The causes of hypochromic microcytic anemia mainly include iron deficiency, thalassemia, and lead poisoning, and sometimes anemia of chronic disease. Skull X-ray shows a hair-on-end appearance that would indicate marrow hyperplasia, typically from either beta thalassemia or sickle cell disease. And then basophilic stippling of red cells is typically seen with lead poisoning. That's it for now. I'll see you next time.